Why do you think it's taken us so long to get here, though?
How do we actually get into effective implementation?
Learning health networks are communities of people, of children, of families, of doctors, nurses, researchers, organizations that are all working together to improve health and well-being.
But the impact that we have through those efforts is limited.
Complex problems like mental health don't have simple solutions. There's no single group, there's no one organization, there's no one sector that can fix the problems alone. And the only way to make that happen is to organize very large communities of people who have a sense of commitment to the kinds of outcomes that we all expect from our health and mental health care system.
So excited today to have with us Drs. Dan Hyman and Peter Margolis. Dr. Hyman is a quality and safety leader in the space of pediatric healthcare, and Dr. Margolis is the former co-director of the Anderson Center and a professor at Cincinnati Children's. So thank you both for being with us. As you know, we are doing this series on the value proposition of Medicaid and EPSDT as it pertains to youth mental health. But a lot of the conversation leads to sort of this final space of how do we actually get into effective implementation? Because so often we see a very significant disconnect between the people who use the system and those who are trying to operate it, which is where you two come in with your expertise around learning health networks. So I think where it would be great to have you start is just tell people who have no idea what a learning health network is, sort of generally speaking, what are these? And then we can talk a little bit more as we go about how this applies here in this setting.
So complex problems like mental health don't have simple solutions. There's no single group, there's no one organization, there's no one sector that can fix the problems alone. And as a result, people, children, families, caregivers working in the systems suffer, often at great loss to society. Learning health networks are communities of people, of children, of families, of doctors, nurses, researchers, organizations that are all working together to improve health and well-being. It's a replicable approach that Dan and I have been working on for well beyond 20 years that allows everybody in healthcare and other large systems to collaborate to create and test and implement solutions, life-saving treatments, processes, scientific breakthroughs across large complex systems like healthcare.
That's great. Dan, what would you add?
So I would just add that learning health networks have been really effective at strengthening and accelerating the improvement work that we try to do in healthcare pretty routinely in a clinic, in an individual hospital, in an emergency department. You can work on a particular issue and make changes in a local environment. But the impact that we have through those efforts is limited. And what we've learned over the last 20 years is that when we get groups of clinicians and, really importantly, patients and families, researchers, policy people together, and we work across different organizations and do it over time, that we can have a much greater impact on the systems that need to change in order to improve outcomes. Everyone who's ever heard me talk has heard me say, and I didn't come up with this, Paul Batalden did, but it's kind of the first commandment of quality improvement, is that every system is perfectly designed to get the results that it gets. And so if we're not happy with the results that we're getting in any domain, for the purposes of this conversation, the diagnosis and treatment of behavioral health problems, we have to look at the entire system. And that's what learning health networks are designed to do.
Yeah, so my first experience around the space of a learning health network came in understanding how it's been applied in a quality and safety space. And so for people who don't live and breathe quality and safety work in a hospital, I mean, when you think about what it means to bring together people whose whole career is about making sure they heal people and saying sometimes we're not doing that well, or sometimes harm occurs and sometimes significant harm occurs, and then being able to create an environment where solutions can come out of that is pretty outstanding. And if you can say more by giving a couple of examples, perhaps, about how learning health networks have been successful in other spaces, then we can kind of come back into and talk about why we think it's going to work here with respect to youth mental health.
Sure. I mean, you're exactly right that the people that are working in healthcare are passionate about the work that they do and committed to trying to do the best that they can, but the system is getting in their way. And so when we involve people in doing work, doing improvement work that helps them to get better results and makes it easier for them to get those better results, it's a really, and people love it. I mean, they love doing this work. And when you go to a learning event, a learning session of any of these learning health networks, the excitement that is evident, you just can't miss it. People are really excited to be doing this work. I've been really fortunate to work in a number of different ways with learning health networks. One, which I'll talk about to answer your question, Heidi, is called Children's Hospital Solutions for Patient Safety. And then there are a number of other learning networks, and Peter can talk about a couple of them. I've been really fortunate to work in different ways with different learning health networks. One of the most successful is Children's Hospital Solutions for Patient Safety, where I was really privileged to be on the clinical steering team for the network and help get it started more than 12 years ago. And in addition to working with the national leadership group for the network, also was sponsoring the work in my role in the hospitals in Children's Colorado and then at Children's Hospital in Philadelphia. And then there were a number of other networks where I wasn't involved in the leadership of the network, but my teams in our hospital were participating in networks that were focused on improving inflammatory bowel disease care or juvenile arthritis or renal disease and so forth. The Solutions to Patient Safety grew from the original 8 children's hospitals in Ohio to 33 children's hospitals across the country that got together in about 2012 and has since then grown to be now 145 children's hospitals, all working together to reduce and ultimately eliminate preventable harm that occurs to kids that are being cared for in our hospitals. As of February, I think we've estimated that 30,000 children have been prevented from being harmed, and we've also saved over $650 million doing that work and had a 30+% reduction in events with serious harm. And so the power that is evident from these networks, the people getting together and working in this way, have been replicated over and over again. I mean, there are over a dozen of these networks that Peter and I have been, in some way involved with, Peter especially through the Anderson Center. And, we're really excited about what we can do with this in the mental health area.
So, Peter, as you're going through some of the examples, I think it'd be great if you could talk about COVID also, because that touched so many of our lives. But Dan, when you talk about these networks and the amount of impact that they have had, I'll just say as a parent, it transforms how I think about places where my kid is going to receive care, where you have people participating in this robust, very collective approach to creating successful outcomes. It makes me feel better about where my child is going and the kind of conversations and attention to issues that are happening there. So it's really powerful.
Yeah, and if you had a child with inflammatory bowel disease, you would not want to be getting care in a hospital that wasn't participating in the Improved Care Now network. You wouldn't. And we'd like that to be the same for behavioral health care eventually, that, the places where people take their children, where people go to get care, are using the most up-to-date evidence and doing it in the most effective way.
It shouldn't, what we say is it shouldn't matter whether you live in rural Colorado or Denver or Boise or rural Wyoming. It shouldn't matter where you are. Should not be what determines the quality and effectiveness of the care that you get. And the only way to make that happen is to organize very large communities of people who have a sense of commitment to the kinds of outcomes that we all expect from our health and mental health care system to make that happen. Well, just one other, just this has not been all about hospital-based care. There's a community-based network in Cincinnati that focuses on helping children thrive, and across the community, they've seen a 40% improvement in third grade reading across all the kids in Cincinnati public schools. There's been a 20% reduction in hospitalizations for children from the most at-risk neighborhoods. And for kids with rare diseases like very serious congenital heart disease, we've seen reductions in mortality, 40% reductions for the most serious congenital heart disease across the entire country. So we're really encouraged by the methods, using them in a variety of different areas, and that's what has led us to also start to do this work in serious mental illness as well.
So if I'm putting a fine point on this, it really sounds like in different language, it is breaking down those traditional healthcare silos and really focusing on collaboration, not just from a community standpoint, but within healthcare that really, I'm going to use the words, feels more wraparound and supportive in how we are approaching treating those who need healthcare. Is that
Yeah, it's totally true, Jason. And the thing that I would emphasize is the role of patients and families in these networks, particularly those that are focused on kids with chronic conditions. We've been to conferences where patients talk about their experience, and when you involve kids and parents in their own treatment decisions, we do different things, and we do better when they're fully engaged in their own care. And I'm sure that's going to be as true with behavioral health as it is with anything else. This is not just about doctors and nurses getting together and saying, how can we do a better job? It's doctors, nurses, patients, families, researchers, as I said before, and really importantly, using data to learn and continuously improve.
What's been so interesting to see validated in this series that we've had in other conversations is just this kind of foundational element of connection, and how that is fostered through this humanistic approach of storytelling around this was our experience, or this is how we were met with the challenges that we were facing. And, what I love about that kind of foundation of connection is really just this sense of community that it builds, but it's a people first approach that I think is so often missed, that we don't really see the person, we see the challenges collectively. And I think kind of ratcheting back down into this individualized approach to help with the collaborative really is moving us forward.
One of the things that's characteristic about how this works is, how do you get people to come together? And what really brings people together is a set of expectations about the outcomes that we should all be aspiring to. It's very hard. We all work in our silos and we all see the limitations of what we can do. What gets us out of that, and when we build these communities, is that we really start with what we all expect the system to be able to produce. Its effectiveness, its efficiency, its access, its affordability, I mentioned equitable outcomes no matter where you are or who you are. That's what brings people together. And at some level, even having those conversations requires a certain amount of trust, because people have to let their hair down. They have to admit, well, the system really isn't as good as we want it to be. And we're willing to be honest and transparent about that. And that's where the data comes in. So outcomes are important. Data-driven decision-making is important. Building the community relationships and the community itself and the trust. And then, as Dan already mentioned, the tools and methods to actually change systems. This is hard work, and there are methods that you can learn, that anybody can learn. And in fact, we're teaching parents, we're teaching school teachers, mental health providers, how to use the methods to actually build the kinds of systems that they really aspire to have.
Well, and aside from that, I think we come into these conversations with a lot of expectations about what should be happening or what we think needs to be happening, and recognize that there are many failure points that, it's not pointing one finger at one thing necessarily. It's a lot of things, but I think that expectation piece is really fraught with landmines when we start looking at changing systems, because there are a lot of access points to the system, a lot of people involved in the system. And if we all come at it with an expectation of how it should be, frankly, it's kind of a recipe for disaster to start with. And then we want people to trust us and be vulnerable. Like it's a big lift.
Yeah, I think allowing people to have the aspirations and then also be grounded in today's reality, and recognize that getting to the aspirations requires step by step, almost, I like I think of it as, I mean, it truly is pioneering work in the sense of we work on this with the tools that we have available and make the most of them. And if we keep that up and we can organize a big community, that's what we've observed is very large scale impact by enabling people to have the tools and the mindset that you need to actually kind of get into this learning, testing, pioneering way of working.
It's probably worth just, at its most basic level, this work depends upon recognizing that there's a gap between care as it is and care as we want it to be. And recognizing that, and it's what you were talking about, Jason, in terms of having a common objective. We start with something called an aim statement. What is it that we want to accomplish? And we write that down and we put a time around it that by a certain point we're going to accomplish this certain thing, have a measurement system in order to track our progress, and then implement a series of changes and tests of change in order to accomplish the objective. And everyone's doing that together. And it's really important. One other thing to say is that we're not competing with each other in these networks. Hospitals get together who compete on all sorts of things. They compete for philanthropy. They compete for international contracts. They compete for talent, but they're not competing on results. We're not competing on safety. We're not competing for who's going to be better at treating, name the condition. And we create a community where everyone's interested in seeing that the collective result for everybody is going to get better, that the percentage of children who have well-controlled, name the condition, is going to go up because of the work that we're doing together. Or the number of children, the rate of children who are going to be harmed in our hospitals collectively is going to go down. And that is extremely powerful and motivating for everybody that's involved in the work. And when you see the successes, it just, it's self-reinforcing.
Well, I love how you called out the competition of it, because the one thing that we never talk about when we talk about all of the reasons that organizations compete with each other, nobody ever really owns the fact that there is more than enough business to go around. Unfortunately or fortunately, the need is great enough that there are plenty of people to come and fill the beds or the spaces that you have in your hospitals and your systems. But I think that's a very real thing to point out, that competition has been a major barrier in many respects from us moving forward in some of these really vital services that ultimately have the common goal of helping people.
Another quote from one of our mentors, Paul Batalden, is that the only competition is unmet need. And we certainly, in the field of mental health, we certainly have that. One thing I want to emphasize is what the role of, I will use the term patient, and I prefer to use the term people. What the role of people who are living with various conditions is in actually motivating the change. So we genuinely treat this is not patients or families as advisors. This is patients and families as full partners in defining what we do. And let me just give you an example of what I mean by that. So one of the newest networks that we're starting is focused on people living with bipolar disorder. And we recruited 16 care centers to come together, 16 hospital health systems to come together, and a team and a group of about 25. They call themselves experts by experience. There was a whole discussion we get together to design, well, what is the aim? What should we really be working on? And this is a group of psychiatrists, internationally known psychiatrists, who got together and got into a huge debate about which diagnostic test to use, which one was better than the other. And what emerged from that conversations were that the people who had lived experience had an incredible influence on the actual measure that was being selected as the thing that we were about and the outcome that we were about. Basically, they said, we're listening to you guys have this big argument. We need to be talking about our well-being, and we don't want to have extensive measures that are where we feel like, we're a test subject. We're actually using tools to help learn about our experience and make us better. And so that completely changed the approach that the group has taken.
Well, when I listen to you say that, Peter, when I start thinking about the application of that approach in the state of Colorado specifically, as it's working to think through how to better implement a more functional approach to EPSDT and having it really serve kids with youth mental health. What is it about the Learning Health Network and how it's been used in these other settings, both in a community-based approach and in sort of disease-specific and quality and safety-specific models, that has you feeling like we could really use this to bring to life a new way of delivering mental health care that works better? Why should people be excited about this? Because I am.
Yeah, I mean, for me, the problems in mental health care are just enormous. I mean, the amount of fragmentation, the role of the criminal justice system and crisis care as something we focus on because we're not able to focus upstream, the lack of use of evidence-based tools, it really is a mess. And in order to solve those problems, no organization is going to be able to do it just by playing their role. They've got to be aligned. What gives me hope is that we've been able to work in very fast-paced, complex systems to actually bring people together by taking the time to get to a common understanding of what we're after, building up the trust that it really is okay to aspire to something, but we're going to work step by step, and then we're going to be transparent and honest about what our performance is today. And that takes a little bit of time to get that designed, but it's not, because it's about relationships, it's about connections, it's about our humanity. But once you get through that, we've all become very encouraged by the depth of commitment and the participation that people have.
Why do you think it's taken us so long to get here, though? Because what you're talking about seems like a really practical approach, kind of people-centric, person-centric approach to meeting them where they are. And you mentioned that word competition a minute ago. That's really struck with me. And having worked in mental health for quite some time now, like that has always been kind of the elephant in the room, that nobody wants to get in the sandbox together. And it's like, to your point, not one organization is going to solve this. So like, I'm wondering why it's taken us so long to evolve to where we're actually calling the elephant in the room out, that we're all going to have to work together.
Let me answer the question this way. There was not a systematic approach to improving healthcare and healthcare systems until 25 years ago, roughly, late 90s. And the early work that was stimulated by the TAERS Human Report that came out from the Institute of Medicine, which is now National Academy of Medicine, in 1999, said that 44 to 198,000 people, die in United States hospitals every year as a result of error. That catalyzed a lot of improvement work and multi-stakeholder involvement. And, we would still say that we haven't accomplished as much as we need to over the 25 years. But it's, in the grand scheme of time, 25 years isn't that long. Now, we've had to go through similar learning processes, starting with safety, certainly in the area of health equity, and now in the area of behavioral health, to be willing to put the problem front and center and make it visible and say it's okay to talk about the fact that there's too much harm, or there's too much inequity, or there's not good enough results for children and adults living with behavioral health conditions. So it requires naming the problem, making it comfortable to name the problem, bringing in the knowledge and the experience of people who do improvement work, and then, as Peter was saying, building the community of people to trust each other and get to work on it. So on the one hand, it's taken maddeningly long, and we're like, why are we only doing this in the small number of conditions that we're doing it? But on the other hand, Hippocrates said do no harm 2,500 years ago, and we're still working on it. So, I think we are where we are, and the energy and enthusiasm and the knowledge that we can work with and the experience that we can build on is applicable to behavioral health conditions, just as it is to other chronic diseases, to safety, to educational ineffectiveness.
This is a very human process that, as you're saying, that in many ways is a little different than people who are leading large organizations often are constrained by what they believe they're able to accomplish. This is a different style of leadership I like to think of it as facilitative, participatory, encouraging. In these networks, the leaders are leading through influence, and we're actually trying to grow leadership behaviors in everybody in the community to build a sense that, I do know something that could make a difference, and there's a way in which I could make a contribution and be part of a larger movement. And as humans, we do that in our entire life. We get together as communities to have dinner, to play guitar, to do whatever. And this is a way in which we can get together to solve a big problem, which as humans, we find very meaningful.
Well, and broad scale culture shift obviously is not a quick process. And I mean, really, that we're talking about creating a different culture of treating people. And Heidi, you had mentioned something earlier that really is curious that I'd love your thoughts on about the effects that COVID had on kind of bringing some of this stuff into the spotlight. Because in the work that I've done specifically, what I've really recognized was, we had a demand that was placed on the system that the system was never designed to meet. But also we had people beginning to talk about mental health in a way that they never have or never would have before. Like, did that prime the pump for being able to do this work more efficiently and effectively today because we went through that as a collective?
Yeah. I think Peter can speak, and Dan both can talk about how the COVID instance itself, as it pertains to the development and sort of deployment of a large-scale learning health network model, really set the stage for a highly effective approach to community and a whole diverse set of providers working together. I mean, having come out of the hospital side myself specifically, it's one thing to coordinate exchanges among entities that speak similar languages, have similar processes, understand how to collect and share data in one specific way. What I think was so unique both about the Cincinnati Community Project as well as the management of COVID patients was that you were taking a broad swath of groups and people and entities that weren't doing all those things the same way and saying, we have a sense of urgency and we're going to have to do this without those shared common sets of organization and language and data exchange. And Peter and Dan can talk about like what it was about a learning health network that made that work.
Yeah, I mean, what we were faced with, our team here at the Anderson Center was asked to build a analytic system for our region, which has 20 different hospitals, 2.2 million, 3 states. And what we did was kind of build this up from the bottom. If there were ever a system problem, COVID was it. The hospitals were hoarding their masks and gowns, and the nursing homes couldn't get enough of them. And patients were hitting the emergency department because they couldn't do isolation. And so we had to find a way to get cooperation across nursing homes, across jails, schools. And the way we did that was we started to show people data about what was actually happening. And so in our place, we had literally every morning, there were 20 hospital chief medical officers who would get together and look at the data from the entire region. Where were the outbreaks? How many patients were in the ICU? And these were hospitals there's only one children's hospital in Cincinnati, so we're sort of privileged place. So there's no competition. We could be kind of a neutral convener. There are 20 intensely competitive hospitals, and sharing information about how many patients you had in various beds was not something that anybody wanted to do. And we got to the point where actually one of the chief medical officers said, we're not having any baseball right now. And so the only statistics that I really look forward to every day are the COVID statistics that we get to talk about, so we can look at predictions of who's going to have how many patients in each bed. And so that kind of transparency and allowed us to build this kind of community approach. We all know that there were many things that didn't go well in COVID that we would regret, that we didn't communicate as well as we could, that we didn't involve people the ways in which we might have. And it was obviously a unique experience, a unique time, a unique set of urgency. But in some ways, mental health care, we can learn from that. Mental health care is certainly as big a problem, and we need to learn from what went well and also what didn't go so well.
Right.
Well, when we think about how we're working quickly, again, to your point, Peter, to address the youth mental health crisis, because it continues to be a crisis. Suicide remains a leading cause of death for kids in this country. The fact that we have the incredible expertise and enthusiasm from the two of you to come together to work with a broad swath of entities to make this work is really exciting. And so I know both Jason and I are excited to remain in this conversation with the both of you. Like we're talking about this here and now as part of this series, but I know we'll want to come back and talk about how this is going, because the honest truth is people who are listening to this podcast will be could have a role in this. Like they can be part of the Learning Health Network. They can be owners and drivers of solutions. And so I just, I can't thank you enough for being our partners, for being here and for talking about this. And I'm sure Jason has some thoughts to share on that too.
No, I've had a lot of thoughts here, but I mean, this has been really illuminating. I'm grateful to see leaders like yourself really taking charge of how do we do better? And that's hopeful. And I think for anybody that's listening, I felt a lot of hope out of this conversation. And it's so timely in that there are not a lot of hopeful things for us to get excited about. And this is among them. So thank you both for the work that you're doing to kind of move this forward. It's impressive and it's hopeful.
Yeah, well, I'll just add, I'm really, we're always excited when we talk about this, that people get excited about it, because it's such a positive thing at a time when there are so many things not going well. And, this is an opportunity for us to take something and make it better. And it's not just the two of us. There are a whole set of people that we work with that are experienced in doing this, bring different skills and expertise. And we're looking forward to connecting with the community there that you represent and work with, and figure out how do we stand up something that will really make a difference for kids and for families.
Well, we can't thank you enough. So thanks to both of you. We'll look forward to having you back and talking about how it's going and what we're finding as a result of this partnership. So thanks very much for joining us today.
Thank you for having us. Yeah.